Welcome back all to one more series of lean in RCM. So we are going to see what is a lean, how we can use the lean in your RCM denial methodology, right? That's what we are covering today. And that's what our target is. And we discuss about the timbered, what is the seven waste in the RCM process, how we can improve on. And these are all the things which we covered in the previous training sessions. Today, our topic is how we are going to reduce the denial on the diagnosis related denial. Okay, that's what our topic today. See, when you look into the diagnosis, okay, so this is a very, very simple diagnosis, and most of the time you will not get this kind of denial at all now. Because whenever you change from ICD 9 to 10, this is the bigger problem. Or if you're not following or if you're not upgrading your PMS every year, right, that will be a problem. So usually what will happen when the year is changing, 24 to 25, when we cross over to the next calendar year, there is a lot of diagnosis code change, a lot of CPT code change will happen. Mostly the PMS will take that into their review and then they would have been fixed it. So you will not face this kind of problem regularly, right? So even if you get these kind of problem, what we can do? See, first thing, what you need to do is you check your CPT code and diagnosis code combination, and is it previously paid? Okay. And what you need to do, filter your code by diagnosis and then check it, is it previously paid or it is not previously paid. If it is previously paid scenario within that particular year, you can call the payer and then send this claim back for reprocess. And there is no previous payment. Okay. And you can check your validity, your DX validity. What do you mean by validity? For example, if in 2025, some of the diagnosis code become inactive diagnosis. Similar to the CPT, it will become an inactive diagnosis, inactive CPT codes. Okay. In that scenario, what will happen? Your diagnosis code will not get paid. And you check the validity, and if your DAS or your diagnosis code is active for the DAS, that is an incorrect denial by the payer. You can call the payer and then send it back for reprocess. For example, your diagnosis code is inactive. So that there only your problem starts, right? You will send it to the coding review and build the corrected claim. The diagnosis code can be changed only by your coding team based on the medical records, right? They will refer the medical record and then they can select the correct diagnosis code. So this is what the problem or a discussion what we are going to do here. See, when you look into the diagnosis, okay, I'm showing my Excel sheet, okay. If you look into, there are three or four different denial codes, right, which is associated with this particular denial type. One is 146, okay. So 146, it talks about your denial, okay, the diagnosis code invalid for your date of service. This is what we are talking about, the validity of the diagnosis. And 167 and 256, okay, these two are a very critical denial in the diagnosis. See, for example, what the description says, this diagnosis code is not covered and service is not payable based on the managed care contract. See, sometimes what happens when the contract is signed based on the diagnosis code part, right? What all the diagnosis code can be treated by the doctor, which cannot be. See, basically, there are, you have to, when you are doing a credentialing, all the doctor's taxonomy code and other thing you have to enter into the credentialing grid. When the sum of the taxonomy is not entered and the doctor is not eligible to do the service, this kind of denial also you may get when it is 167 and 256. And apart from that, if you consider some of the diagnosis code related to the patient weight, okay, some patient weight is not sufficient, especially the infant, right? When the diagnosis code cannot be used for the infant, that's a newborn child. We cannot use that. Okay, that's one challenge. And the other things are adjusted based on the diagnosis. These are all non-covered diagnosis. This is also the credentialing. When your denial code gets B, that is mostly relevant to your diagnosis or credentialing related problem. And the diagnosis code missing invalid, these are all the regular. So you will get these kind of denial codes based on the diagnosis code. Okay, coming to the lean, okay, what else we can do? Okay, so the same thing, what you're going to do is we are going to follow the same strategy. And when it is coming to the inactive and you're going to send it to the coding review, we can put a 3 checkpoint here for your pre-billing audit review. So sometime what happen, your diagnosis code may be the truncated code. Say, for example, if it is a 5-digit code, your PMS is not releasing that 5-digit code properly. Okay, there is a truncation, may be an issue. You go ahead and then identify what is your problem on the truncation side. And if you're able to fix that particular code in your PMS, you will not get this denial again. There is one way, whenever you entered any of the code incorrectly, most of the PMS will give an alert message there itself. So you will not cross that and then you cannot enter the wrong code there. That's mostly all the PMS will have. If any old PMS you have and it is not giving any, that intelligence, that will become a challenge for you. But I don't think so now the PMS have that much of incapable PMS. I didn't see anywhere. So it will be a better one. You can fix it there itself. And second one, take a charge report on a daily basis, run by the particular diagnosis code, and then send it to the coding team, ask them to fix it. So this will solve the problem. You need not wait till the denial. And as we discussed, 256 and 167, these denial codes are related to the credentialing, right? So when you have these kind of denial, you better check your taxonomy code, which we created for a credentialing, and how we are going to improve on. Right? This very simple denial, and most of the time this can be fixed with a 100% accuracy. We can fix it, and we don't have any challenges on this particular diagnosis code problem. There is an edit is available. Okay, your PMS is intelligent enough to show you are entering a wrong diagnosis code. These are all very old denial. Recently, we are not getting it. If any of your project has this particular problem, you identify these three and then understand how we can make this non-value added work into the value added. Right? This is the way we are going to work on this particular diagnosis code